We're great, Donna. So thank you for joining us today. I know. Monday morning at 9:15. Whose idea was this?
I know. It seemed like a good idea at the time.
Exactly. So, so just for the participants, this is Andrea Smith, and we have as our guest Donna Bradbury, the Associate Commissioner at the Office of Mental Health for Integrated Services for Children. It's I'm getting better, Donna. It's getting closer.
Just say the kids division.
I know, that's what I always do. I know, but I want it to be accurate. And just to make sure everyone understands where we are in this discussion, as you know, the governor proposed $5 million in funding for RTF pilot projects in the budget, and that was approved by the legislature. When the budget came out, the coalition provided some feedback about ideas in the direction that we had collectively identified for the pilot projects to go in, and we provided that to OMH. And then, you know, now that the program has been approved in the budget and OMH is ready to start to begin working with you on the pilots, they are going to present, Donna, you can characterize it any way you'd like, but, you know, basically your vision of how you'd like this to move forward.
Great. Okay. Thank you, Andrea, and thanks everybody for taking the time this morning. So I'm just going to do a quick intro, and for clarification, Andrea, do we have until 10 or 10:15?
We scheduled till 10:15.
Okay, all right. I just wasn't sure, so thank you. So I just wanted to take a moment just to sort of frame the discussion, you know, and in terms of where we are with residential treatment facilities in New York State. So, you know, I don't think I need to really tell anybody that's on the line this morning the challenges that that RTF providers are facing, you know, in today's world. Residential treatment really is under so much pressure to evolve at this point in time. You guys provide excellent service, a needed service to kids, but what we're finding generally across the state is generally a decrease in demand for residential beds, and all indications are that that is due to our very active and deliberate growth of home and community-based services. Many of you in your agencies offer some of those services, and you know that we have steadily increased the number of slots across the state of our home and community-based waiver program, and the goal of that program is to keep kids out of inpatient and residential, and it's working. We're also in an era, as everybody is acutely aware, of an imminent transition to Medicaid managed care, and we're readying all of our services for that transition. Hopefully you know that what I've asked for in our 1115 waiver, which is the waiver that we're using to make the transition to managed care, that there be a 2-year delay in integrating RTF in managed care, which means we're 3 years out right now. And we at OMH are committed to doing everything necessary to prepare the field for that transition. We have, as you know, experienced some agencies in recent years either closing their RTF operations completely or having to reduce their number of beds. And what I'd like to see is honestly, a more planful and deliberate reduction in the number of RTF beds across the state, in a way that makes sense, in a way that preserves resources for children and families, and ideally in a way that converts those resources to some form of home and community-based service, which is really the most ideal way, right, to address needs that kids and families have. And so you know that, you know, over the past several years we've had many conversations about how best to ready the field, how OMH can support those efforts. And you know, honestly, it's always a fiscal barrier that we've encountered historically. We have lots of ideas programmatically. We've shared those ideas. I think we together we share a vision for where things need to go, but it's really how do we mechanically alter the financial landscape in order to enable providers to actually get to that shared vision. And so what is that shared vision? It's much shorter lengths of stay. It's much more intensive treatment. Ideally, it's treatment that can be easily adjusted or catered to special populations. It's a much deeper connection between residential beds and community-based services, so that it's a more seamless, if you will, flow between those two delivery systems. Really, I'd like to model what we do after the Building Bridges initiative, which hopefully all of you have at least some familiarity with. A couple years ago, we offered an opportunity for RTF providers to send staff to a training about building bridges. We're looking into the possibility of doing something like that again in the future, but all with this goal of arriving at a future vision for residential services in which children can have a safe and an effective residential setting for a brief amount of time in order to stabilize, and then really the rest of the care happens in the community. So I don't think that vision that I just laid out briefly contradicts anything that we've ever spoken about. Like I said, I think we all really share in that vision. It's just a matter of how do we get there. And so that really rests on, you know, how we structure the financial aspect of a pilot that will allow us, together with providers, to test how exactly that vision is best achieved. And so, you know,
this is Andrea. I just want to chime in at this point. I think especially we want to emphasize the pilot perspective, simply because, as you've identified, you know, if waiver is the program that's having the most impact on reduced demand for RTF services, as the waiver shifts over from its existing level of intensity to what the field feels is a less intensive home and community-based waiver under the health home model, you know, with the intent, as Jason Helgerson, the Medicaid director, has always said in public forums, more kids getting smaller doses of more services, you know. So as we take down the waiver in its current existence, I do think that, you know, we as a field have to be mindful of what that does for kids with the highest needs, because also, and you can address this in your presentation, we've heard that, pursuing high fidelity rep, which we had always encouraged, may not be able to be part of this picture. So I just wanted to make sure that that perspective is also addressed or just integrated into the thought process.
Right. Yeah, Andrea, I thank you for that comment. I acknowledge that reality fully. So, next year we will be transitioning the home and community-based waiver to managed care, and as Andrea pointed out, pulling out the care coordination aspect and transitioning that to health homes. And I think you're absolutely correct that it will not be the same as the waiver program as we know it now. And we acknowledge that, and we need to watch that closely and observe how that impacts service delivery to children. And, to me, the strength that we have in the children's world, perhaps in comparison to the adult service delivery system, is that we have you, the existing providers that are very experienced in delivering home and community-based services. You're very experienced and knowledgeable about what kind of care coordination the highest need kids really need. And so we're going to be relying on you to work together with us to monitor how that transition is going and what what adjustments we need to make to the service delivery system to continue that high level of care. And I think there's a lot more to come. You mentioned high fidelity. I think there's a lot more to come about that. Most of we're running a SAMHSA grant project that's testing high fidelity wraparound and its feasibility and sustainability. So I think there's lots more to talk about, but not for today. Amos Lane is with us now, our Chief Fiscal Officer. And so just to make sure we have enough time for questions and discussion, I'm going to turn it over to Amos.
Sure.
Thanks, Amos.
Okay, so in this year's budget, there is authority to do what we're calling residential treatment facility pilots. So we have a reference to up to $5 million that could be allowed to spend to provide state aid grants to RTF providers to fund projects related to the transition to managed care, as well as redesign and pilot projects. So that reference was something that the budget division supported us in that they understood that beds were closing and the program had some demand decline, and that there was an acknowledgement that of the challenges that the RTF providers face. That if revenue declines, the RTF still has overhead and expenditures, to operating. And what we wanted to do was provide some authority to fund pilots so that we can make sure that you don't have any disincentive to move forward and start to prepare for managed care or start to develop alternative services. So what we have here is a unique opportunity to fund projects up to 3 years. And what we want to do is look at some of the types of changes and investments that we think will be most effective as we move into managed care. So as Donna said, the authority, the amendments to the 1115 waiver are pending. Our expansion of services are pending with the feds, and those are going to be rolling out in the next year. And what we're looking to do is keep the RTF funding in the system and use that to develop crisis and community-based capacity and other alternatives that really use the system more effectively. So what we're looking to do is enter into RTF pilots with any providers that want to move forward, and we're going to talk about a process of how that would work so you could evaluate whether or not you want to participate in a pilot. But we're really looking at two different approaches. One approach is any reductions in beds. Tier 1 is any reduction in beds that results in a decline in revenue, that could be used to provide state aid grants to expand community-based services. And that those state aid grants would be available over the 3 years of the pilot, and you would be basically assured of your revenue loss over those 3 years. And the second approach that we're considering is if there are pilot projects that can reduce length of stay, significantly reduce length of stay, where if you shrink your program and you're reducing length of stay and you're actually serving more kids, that we will explore, a pilot that, preserves revenue to provide those higher level of intensity of services. So the current framework for the pilots for Tier 1 is we are looking for Tier A. We're looking for we're considering pilot funds to expand the 6 new spa services. So these are the 6 new spa services that are pending with the feds for coverage. But this is actually a unique opportunity here. If you have reduced demand for your beds, that you could take beds offline and get a state aid grant equivalent to your current revenue, and that those dollars could be used to support the development of these 6 new services over this 3-year pilot period. And you can move forward with reasonable assurance that you're going to be able to cover all your costs. And then obviously at the end of the period, we're hoping that the expansion that we have pending with the federal government for these services will actually grow. And the financial plan, assumes that. Right now there's an assumption for growth in these services and the number of kids and the spend for overall services. So we're looking at also crisis services or respite services that may be covered in the transition to managed care. So within the 1115 waiver, we have authority to cover crisis programs. And on the adult side, we had a crisis benefit designed, within HCBS. But what we're looking to do on the adult side is come out with guidance to the field on crisis services that are covered for any individual within managed care, regardless of whether or not they have an HCBS plan. So similar to the kids, we have a crisis intervention benefit that's part of the 6 new spa services. But the guidance that comes out on adult, it will really be the framework for something that's extended for kids as kids go into managed care. And so we'll get you more guidance on that. But a crisis residential program, we believe, will be part of a future state. And then also in the current benefit package, we have licensed outpatient programs such as partial hospitalization. We also have guidance coming out on intensive outpatient treatment, which allows for more intensive clinical treatment. So all of these services here that we would consider for the expansion on the community-based side with state aid really are part of a future benefit package. So what the pilot does is it allows you to shrink some of your beds and get a state aid grant over 3 years that gives you definitive security in terms of revenue, and it allows you to start to establish these services and generate billing and really mature the program so that at the end of the pilot, we hopefully have a program that is more expansive and larger than when you started. Because I think the biggest thing that we heard from the field from all of you is that you can't close beds. You're trying to fight to change the pack, to get more referrals, even though a kid may not need a long-term residential stay. And this really is a framework where we're removing that incentive to keep running beds and trying to move to future state where we know the system will grow and expand. And we believe that you are, as Donna said, you are the deep end kids providers. You guys are going to be in front developing these new services and expanding, meeting the needs of your community. So we think that this gives you the framework to do it with more stability and security. So Tier B. So the second thing that we are considering is that if you were to close and shrink beds, we're considering pilot proposals that would commit to and achieve significantly shorter length of stay within an RTF. And we all know that if length of stays are reduced, access is actually increased because more kids can come and use those beds. So right now, one of the biggest challenges is RTFs tend to be a longer term residential placement. We know we've all had discussions in the past about commercial insurance and commercial insurance plans that are contacted many of you and explored whether or not they could put in place contracts for shorter lengths of stay. And I think one of the challenges that we've always heard from the field is, the intensity of services, the resources. So I think we're open to a discussion on, if we're able to shrink the program and put in additional resources for reduced length of stay. We think that that's moving the system in the right direction as well. So that's something that we want to have dialogue with everyone on. So let me talk a little bit about the RTF mechanics, because that's really the framework that you need to evaluate if you choose to move forward in this project. So we're really looking for the identification of any vacant or underutilized RTF beds. So those may be programs where, at different points during the year, you're not at full capacity, and under the rate methodology, you're not able to, recover all your costs. We have had programs that have closed beds in the last several years. And, what we're looking to do here is to work with programs in a more planned and thoughtful way to explore PAR amendments that would either permanently close beds or temporary close beds through the life of the pilot. So that would have to be, any participation in the pilot would have to be through the PAR process, but we would consider temporary or permanent over the life of the project. So we're expecting that those beds would come offline, and that we would have to reflect that on the licensing and operating certificate. So that's the first step of this process. But we'll describe how we're going to approach applications for it and review proposals. Okay, step 2 really is for each approved project, you would receive a state aid grant equivalent to the reduced revenue. So we're talking gross revenue here. So if you could picture, the state really, if beds are closed, the state really only achieves 50-cent savings on the dollar for the state share. But what this pilot is doing is it's committing to a gross grant, so that any revenue decline would be mitigated by the state aid grant and funding these expanded activities that we're talking about in Tier A as well as Tier B. So what we're talking about is we would be working with you to model the reimbursement decline and account for any rate adjustments. So any fixed costs that remain in the RTF rates for beds that continue to operate, that wouldn't be savings. So what we're really talking about is, from a gross budget perspective, what's shrinking here based on your plan or proposal to temporarily or permanently taking off beds, and that those dollars would be available for a state aid grant, and that it would provide for stable funding in a transition to these alternative costs. So it'll help you with startup. It would help you, as you ramp up these new services. And, so that's the basic framework here, and we'll talk a little bit about how we do that. Step 3 is a key thing here. In any contracts that we move forward with for the RTF pilots, there will be a reconciliation. So we talk about here that, it'll be a state aid grant that's equal to your projected revenue decline based on the proposal. We'll be adjusting, the rates. And then to the extent that revenue came in greater than whatever it is we assumed, we would have a provision in the contract that allowed for the reconciliation, to the actual revenue decline. And, there'll be more to come on, how we structure that and how we work with you on that. But at least you understand the framework of what we're talking about. And what we're going to do to kick off this process is we're going to be issuing an informational survey to all providers in the next 2 weeks. We're going to get that out in June. And that we're going to be asking for some key things. First of all, are you interested in the pilot? How many RTF beds you currently operate? And how many beds you're going to be taking offline on a temporary or permanent basis? We want to understand whether or not you're interested in participating in Tier A or potentially Tier B. If you can also articulate, and we'll lay this all out in a format to make it easy for you, what will happen to your gross budget, and what is your estimate of the revenue decline associated with the identified closing beds. And then that would be confirming what fixed costs would remain for the RTF program. And then obviously we're going to be asking you, more details on what your proposal is for the funds and moving forward. And then if the agency, if as an agency you're not interested in submitting an RTF proposal, so maybe your beds are completely utilized and that there is a community need, we would ask the agency to respond and decline interest and participation. And that's really, you know, for the fact that, you know, we're going to be doing this through, you know, through a framework where everyone has equal access to participate under the same exact rules, and we're trying to gauge, can we fit, you know, all the pilots under the box we have, and you know, so that everyone can participate who wants to, that has a viable proposal consistent with our rules. And if for some reason, you know, we're going to be evaluating the response to these surveys, if the responses are much more expansive than what we have in terms of the budget appropriations, we'd probably have to do an RFP where there is competition against scoring. But our hope here is to you know, basically fund any project that is viable within Tier A. I think Tier B is a little bit more complex because Tier B really involves this commitment to shorter lengths of stay and starting a transformation of the inpatient services. So I think we want to gauge, you know, what's the extent of Tier A participation of shrinking beds and expanding community-based services. And then, you know, as we look at those and get those moving forward, we'll be evaluating, you know, what it is that we could fund or entertain from Tier B. Because Tier B could be a combination of staying within the Medicaid rates and trying to shrink the program and adjust resources and more aggressively, you know, reduce length of stay. So I would think that in this process, the Tier A proposals are going to move forward much sooner and go live, and then the Tier B proposals will be something that you know, will take a little bit longer to design, you know, with you. But we're very interested in both.
Great. Thank you, Amos. Very good. So at this point in time, we'd like to open it up for questions or discussion. Hear what you guys are thinking.
Nicole, could you take everyone off of mute, and people, if you're not ready to ask a question, you can mute your own phone, but we're going to unmute the lines, and hopefully there won't be music or bathroom noises or anything else in the background, dogs. But we'll let everyone open it up so people can ask questions without using the chat box.
Great.
Okay, I am starting to unmute folks.
Hi, Don, it's Bill Getman. How are you? I'm going to ask a question that I hope I have the right answer for. For programs that have already taken beds offline, is there any consideration that we can use that effort to put an application in for?
I think we will look at that, Bill. I mean, obviously there'll be some date that we're pointing back to, but we will clarify what that date is. So, you know, it'll depend on how recent those beds came offline.
Okay. All right. Thank you.
Hello, can you hear me? It's Lenny Rodriguez from.
Yes. Hi, Lenny.
Hi, Emil. Just you mentioned fixed costs. Will you be clarifying the definition of such so that as we calculate, we make sure we're able to separate that from the operational?
Sure. So I mean, the survey is going to be just a very basic starting point. You know, when we're ready, you know, for planning, when we're ready to go forward, we will have, you know, the formal submission of proposals, and we'll be modeling with you, you know, what it means for your rates. So the example, you know, I'll just do a real simple example. If you have 100 staff funding 50 beds, and you're proposing to take off a 6-bed unit, you know, we're assuming the overall 100 staff will shrink, and that we would work on adjusting your rate, and we'll be projecting revenue from your occupancy again. But whatever your gross revenue decline is, that's what we're looking to enter into in terms of a state aid grant and a pilot. So the reverse example of that is if you have 100 staff and 50 beds, and you take 2 beds offline, and you say that you still need 100 staff to run those 48 beds, there would be no ability to provide a state aid grant for a pilot. So the challenge is that we all know when we take off a full ward that there's definitively savings, and then there's also fixed costs that would spread among a smaller base, which would result in a higher rate. But the challenge is, if you're taking off less than a full ward, what are the operational efficiencies that you would achieve, through reduced workload, where you would be shrinking your RTF budget? That even if your rate adjusts and comes up higher over this smaller base, that there would be reduced revenue that we could enter into a contract with state aid.
Thank you.
So I did get
We'll help you model it in the end. I think this initial questionnaire and survey by no means locks you into the final amount. It's just you trying to articulate, what you think this framework means for you in a pilot proposal. You're starting to articulate how much, may be available, what would it mean for your budget.
Thank you.
Yep.
So
Audrey has her hand raised, Nicole.
okay. Audrey, you're unmuted, so you're welcome to speak.
All right, good morning. I have a Tier A and a Tier B question, okay? So relative to Tier A, the expansion of community-based services, spa services, partial hospital, IOP, all of that, have you got a sense of a level of need, level of care determination for those services, given that this is using repurposed money?
Can you be a little bit more clear, Audrey? So, and it might be a terminology thing. So, to me, level of care, level of need, that's about HCBS, not
right.
about spa.
Right. Okay. So I'm thinking that if I have money to build crisis intervention services or, any of the spa, can I offer those to absolutely anybody who knocks on our community-based door?
You can offer that to anybody who meets medical necessity.
Who meets medical necessity?
That's driven by medical necessity, not by functioning as measured on the cans.
Yeah, so I mean the way I would picture this is that managed care is going to be providing access to more families that wouldn't qualify for Medicaid based on their income. So this whole expansion we're moving forward with will expand HCBS services to kids that have commercial insurance, right. And Medicaid will be covering it to prevent this slippery slope of kids, hitting the Medicaid system at some point. So I think the answer to that is yes. So here's a unique opportunity where we would have state aid available to start to develop these services. You'd have stability in revenue, and then as the Medicaid benefit keeps expanding and rolling in, we would expect that Medicaid revenue would cover it at some point once your program matures.
Right. Okay.
And
all right.
Audrey, this is Andrea. I'm just going to chime in. Remember, this isn't Medicaid funds. So right. In terms of establishing medical necessity and eligibility for the program, you could do that in conjunction with, for example, your PPS, right? And there's no risk of doing it wrong in the sense of it's not Medicaid funds. Yeah,
okay.
So just to make that clarification.
That's a helpful clarification. Tier B, when you talk about reducing lengths of stay, what have you got in mind there?
Well, we're really looking at significant, reductions in length of stay. So this is a program that is the average length of stay is greater than a year. It tends to be more long-term residential placement. I think we talked about how commercial insurance really is looking to purchase shorter lengths of stay. Before, our challenge was when we talked about how we want commercial insurance to cover, the cost of care. Commercial insurance isn't going to cover the cost of, more than a year, a long-term length of stay. We're not looking to put RTFs into managed care when we go live. but we know that it's something in the future that we want to design and roll in. And, it's the same for community residences. These are programs that generally require more intensive treatment, and kids are in for a longer period of time. But what we're considering here is, if you can drastically reduce, your length of stay, and under the RTF framework, that currently exists, if we can support that, through a pilot, we'd be interested in exploring it.
Great, thank you.
So, tier B is going to be something that's going to require a lot more dialogue. I think tier A is a lot more cut and dry, because if you're shrinking and your overall revenues are going down, and we can put in place a state aid grant to help you start expanding some of these alternative services, I think that's a lot simpler equation. But we're open to tier B.
Great, thank you.
So I do have a question from Jim Nyreen, and he doesn't have access to asking aloud, so he asked, could you ask if OMH has a mind in an LOS that would be acceptable as a significantly reduced number, 6 months, 3 months, or less?
I think that's one of the reasons why we're doing the survey. So if you sit there and say, I'm interested in potentially participating in tier B, that we think we can reduce our length of stay by X days from Y, to Z, and then these are the types of things that we'd be doing. These are the types of needs that we'd be addressing that would help us reduce that length of stay. I think we'd be gauging, the response from the entire field to figure out, where we can, draw the line. So I think you should articulate that in this initial survey, what you think you could actually achieve through, program design, enhanced program intensity. Well, what we're going to be doing is we're going to be looking at, the current framework for the rates, for the reimbursement methodology. We're obviously trying to function within that and invoke, some of the flexibility we have within that. But there's even a third tier here that I think this dialogue will help inform. And that's really, is there anything we could do differently within the rate methodology that, our partners at DOH, would be comfortable with, and CMS would be comfortable, that would promote reduced length of stay and kids moving through the system, sooner. So I think that's something that tier B could turn into. We could be having dialogue with several programs where you're telling us that these are the types of activities that will help us reduce length of stay, and that we're exploring potential changes to the rate methodology that would recognize those activities. And that's where tier B may actually lead to in the end. So the real question on tier B is, are the types of activities and costs, is it something that could be funded by Medicaid, current state, future state? But we're going to be asking you to articulate what you think you could achieve in terms of length of stay. Where are you currently? Where could you be with these types of program changes? And you guys are the experts.
So I do have a couple more questions. I see Maria Cristalli, I see your hand was raised. I've sent you your audio painter. If you'd like to type in your question in the questions box, I can ask it aloud. And I see Elizabeth Nolan, your hand is raised. Would you like to ask your question aloud?
Sure. Can you hear me?
Yes, we can.
Yep.
Great, thanks. Just clarification, Emil, and you may have said this, but I want to make sure I understand. You talked about needing to demonstrate operational efficiencies, and I'm back to tier A. So if we're not taking a full unit offline, just a few beds, do we need to demonstrate the reduced costs up front, or will that be managed at the end of the 3 years through the reconciliation?
Well, what we'll be doing is we'll be looking at what it means to your rate, right? So we have obviously the rates modeled, and we hired Dave Panizza for some project work, and he's going to be helping us model, what the revenue would be, what the revenue would decline. So I mean, the first key question is when you reduce 2 beds, when it comes to your overall staff and budget, does that result in any change, to your overall staff and budget. And if you are taking out FTEs, then obviously your gross costs are going down and it's being spread among a smaller base. Two things happen there. That gives you probably the ability with more security to achieve full occupancy in your program. So maybe over that smaller base, your occupancy may go up a little bit, which is a positive thing. But there's still, if you're taking out staff and reducing a gross budget, there's still a decent chance that you will have a revenue decline. And it's that we're trying to get at. I think the more complex question probably leads off of if you've been struggling with occupancy and your revenue has been declining, where do we draw that baseline for our commitment to to fund the pilots? And I think that kind of ties to Bill's question as well. If you've already taken off beds, at what date are we pointing to and saying, well, this is what's available? And I think we need to figure out where we're going to draw those lines. But know this, the responses to the surveys are only for planning purposes. And then when we come out with here are the official, rules that basically, we're just trying to figure out where we could draw the lines and what we can afford.
Great, thank you.
So I see, Maria, you are on next, so you may ask your question aloud.
Thank you. Just wondering in terms of the time frames for Tier A and Tier B moving forward with the pilots.
Sure. So we're going to come out with a survey in June, and then our hope is that we'll be able to set up some models for how we're gonna project the revenue decline, how we're gonna manage this, and that we're looking to come out with formal guidance in the summer to kick off the process. We believe Tier A will move forward quicker and sooner. That we'd probably wrap up some sort of Tier A awards in the fall and amend and put in place contracts, and then Tier B hopefully would follow shortly thereafter. But what we're committed to doing is communicating very clearly, even after this planning stage, when we come out with the guidance, what the ground rules are for both. And so then your agency will know, what's the likelihood that you're going to have, something put in place and move forward. So again, this is really an exercise about current state, future state, what's your current demand on your system. This is something that we've heard repeatedly from the field that, keeping beds filled, is a challenge, that programs are at risk, but you really can't proactively take down capacity because, you have overhead and costs that you've got to cover. And then really the overall framework from the state is we're looking to take this KID system and massively expand it. And the challenge really is that, how do you, especially for you guys that run a deep end array of services, how do you help facilitate that? And we think the pilots give us that unique opportunity to, get state aid and give you more stability to start expanding the community-based services. But, we'll be looking at the data with you as well, to make sure that we're comfortable, taking down beds and that, the need isn't there. Yeah, so I think, formal guidance after we get the surveys and do a little bit of work on our end, but formal guidance in the summer. And then, in the fall, Tier A awards, and then Tier B, would follow. But you'd have a clear understanding kind of where we are with Tier B. I mean, Tier B, as I described, may actually turn into some changes to the methodology that would help the entire system. So it really Tier B will result in, I think, some more informed dialogue on, what would it really take to reduce length of stay, to try innovative changes to this program to allow it to be integrated into managed care.
So this is Donna. So I just want to repeat something that Emil said earlier, which is the survey, we're not going to hold you firmly to anything that you write in the survey. It's really for you to start thinking about how you might avail yourself of this opportunity and for us to engage in a conversation.
Yes.
With providers about how best to make your ideas work.
So when you submit the survey, that's for us to plan. When we come out with the official rules, we would appreciate everyone responding in good faith, what they're thinking or what they believe they could achieve. But when the official rules come out, that's when you're making your choice on whether or not, you're moving forward. And you're not bound or obligated to move forward with anything. So as Donna said, the survey is really about planning, about us all rolling up our sleeves, and then and then when the official rules come out, you can make your choice with your boards and finalize proposals that we'll be reviewing. Do they meet the rules?
Nicole, I think that just Lenny, let me just check. Zig Malawicki, I think you had a question. I
have some questions queued up. Zygmunt, do you want to go ask your question?
Sure. Can you hear me?
Yes.
Yeah.
Okay. Current mental hygiene law indicates that the minimum size for an RTF is 14 beds. For 14-bed RTFs, does that mean that Tier A is not an option?
We are exploring that. We believe that there is some authority within the current regs and the current framework. But we need to look at that. You mentioned mental hygiene law. My recollection is that was in regulation.
Okay.
So we're examining that. But what you should do is you can respond in your survey, your response to these questionnaires. You can respond, with a Tier A and a Tier B approach, and we will have to, in our final guidance, come out with a rule or a framework for the smaller programs, because obviously we put the 14-bed limit in place because we wanted to promote an efficient and economic program, and the more you shrink, the more costly it is to run a smaller, inpatient program. But that's something that we are seriously considering, that we have an openness that, if it makes sense for you to shrink a little bit further, that, we will be looking at the regs to make sure, one, we have the authority to do it if we allow it, or potentially amending the regs.
Okay, thank you.
If it's in law, we don't have a chance. I think it's in regs.
Okay, thank you for clarifying that.
Our pleasure.
So I have another question from Heath Block. Are there any restrictions on the types of services that can be offered as alternatives? For example, children's, ACT themes, etc.?
What was the service?
ACT, did you say?
Yes.
ACT. So we haven't had a conversation specifically about Children's Act. I think if you have a specific idea that you want to propose, I would say put it in the survey and we'll have a conversation. Sure. I don't want to say no right off the bat, but we do want to encourage the growth and delivery of the new proposed services, and in the expansion of services that we are confident really meet kids' needs. But if you have an idea, put it in the survey and we can talk.
So I think that dialogue will really be focused on, is this something that the state should be considering putting it in the benefit package? But our challenge is, if it can't be covered at some point, that we don't have the ability to continue these pilots beyond the 3-year period. It's about sustainability. So this is your chance to start moving the system forward, and then we may do a future round of pilots if these were successful. There's more need for it, but the challenge is that we don't really have a Children's Act service. But may this potentially help us evaluate that? Yes, but if we go forward with something like that, it'll also be an exercise of us evaluating, can it be part of a future state benefit package?
This is Lenny Rodriguez. My question is, if you, in reduction of beds, if you have a variety, more than one RTF, are you able to reduce cumulative and then apply to different pilots at different RTFs?
Yeah. So are you asking about interchangeability? So obviously you have a rate for each facility, Lenny, right?
Yes.
Yeah, so I mean, I think it would be driven off of what the revenue decline would be at each facility, and then whether or not we hold you to use those dollars in the community that facility was serving. That's a policy decision that we'd have to figure out. But we'd probably be putting in place one overall, contract, covering all of that. And I think, the larger your system is, like in your case, probably the more ability you have for some interchangeability. So if one, but I think the challenge is, these resources are serving a certain community. I think that we would want the plan, to address needs in that community. But I think you would have a certain flexibility in terms of, how we close it out and how we reconcile, because you have a bigger scope of programs.
Okay, thank you.
Yep.
And Emil, this is Andrea. I just wanted to put out a question that I've gotten from a few people so everyone understands. This pilot project funding is completely different from the statewide health facility transformation RTF process. So
yes.
As you know, the budget included additional money, of which RTFs now will be eligible to apply to the Department of Health for. And that money is for different purposes. That could be for debt restructuring. That could be for capital projects to change your actual building. If you say you wanted to test taking a 4-bed unit off and doing a crisis, residence unit or a crisis response unit, that money, that capital money could reconfigure your building. So you're not going to get money to change your physical plant from this project, but you could get it from that project. And I just wanted to try to clarify that.
I think that's really helpful, Andrea. And then there's another $10 million that's available within the budget, capital funds for children and youth, and we're looking at two different areas, potentially for participation. But that will be done through an RFP process. And, it may include RTFs as well as kids clinics. So that may present an opportunity for, if you need capital physical plant changes for whatever your pilot is, that may be an opportunity to get capital funds for those changes. But as Andrea said, we're really talking about operational dollars here. But we get that capital is a key component of this. So as you convert beds, you may need to modify space, and these other two sources may be potential ways to fund those changes.
Any other comments, questions?
I have not received anything yet, but last call for questions.
I have a question. Can you hear me?
Yes, we can hear you.
Okay, this is Zig Malowicki. I guess just one last question. Obviously, for an RTF to consider going into a Tier B, you have to have an awareness of what the whole system is doing. Is there going to be a cap or guideline put on how many beds will be reduced as a result of Tier A?
I think we're going to be looking at, you're absolutely right, we're going to be looking at community need and demand. I mean, obviously you guys are experts on, the referrals you're getting from the PAC, vacancies, throughout the year that you may experience. But we will be looking at overall community need. And we're not going to let programs, drastically go below what we think the demand is. And we will be looking at, other programs in the areas and referrals. So, we don't have a clear line that we're drawing now, but we will be looking at data, are your beds fully utilized? What's your length of stay? What other community hospitals exist in the area? Article 28 inpatient, Article 31 kids CPC programs, are they fully utilized? So we will be making informed decisions on that, because as we said, any project that moves forward needs to be amended on a par, and that's really what the framework is for any licensing change review.
Okay, thank you.
Thank you.
And Zig, this is Andrea. I just want to follow up on this because, Donna, as you know, we got a couple of pointed questions about this proposal from the advocacy community at large.
Yes.
So anyone that's responding to the survey, I just strongly recommend that you reach out if you have a youth peer board member to your family groups to get some input about services they feel are important. And lastly, your local mental hygiene director about their feelings. It doesn't need to, I would document that you've done those things. I don't want anyone to get criticized, including OMH or the coalition, that we're not taking into account, you know, the sense of community input. And plus, you may get some feedback on what you're thinking or refine some of your ideas.
Great. That's a great idea, Andrea, and we will be doing the same with you, with the conference and the counties, to make sure that there is local input.
Yeah. Good.
All right, well, we've reached the end of our scheduled time, and I know that I had said that maybe the RTF provider group could go on for a little bit longer, but why don't I reschedule a separate call so we can just talk amongst ourselves, but we certainly appreciate the time and effort that Donna and Emil have put into thinking this through for us, and of course we, you know, welcome the opportunity to have operating funds available and then the potential for capital funds once we find out what's working. If we want to make physical plant changes, that would be a great next step. And we will, all the RTFs will be hearing from the coalition about a follow-up call within this week, okay? Not the call this week, but at least you'll get a message about a call, all right?
And then, and our survey will be out in the next, before the end of June.
Yeah.
And everyone will get notices on.
Well before the end.
Yeah, great.
Yeah. Yep. All right. Thanks, everybody.
Thank you very much.
Thank you.
Bye.
Okay.
Take care.
Bye.